2, and 1. We are live.
Good evening to all our viewers of OrthoTV. A warm welcome to you all. We are here with the 12th episode of the second season of series and controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with an interesting case presentation followed by discussion in each subspecialty of orthopedics. This season is dedicated to the young orthopedic surgeons having interest in each subspecialty of orthopedics with the goal of uniting skill with mastery, where the presentation is being moderated by an expert in that field. This platform is not only aimed at helping the young orthopedic surgeons to present their case and strengthen their communication skills, but also reach to a broader and more diverse audience through our OrthoTV channel, thereby increasing their visibility and exposure. This program is conducted under the chairmanship of Dr. S.S. Mohanty and Secretary Dr. Ashish Phadnis, Dr. Mrinal Sharma, Dr. Swapnil, Keny, and myself, Dr. Deepak Gautam. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at SACHIN Medical College and KM Hospital, Mumbai. He is an honorary consultant at Jaslok, Nanavati, and Sushrisa Hospital. He is the past president of Bombay Orthopedic Society, an academician and a researcher. Today, we have three brilliant young orthopedic surgeons, one each in spine, trauma, and pediatric orthopedics, with an expert panel including Dr. AGNIVESH, Dr. SACHIN, and Dr. Sandeep. In absence of Dr. Mohanty, who will be a little late in joining, I would now like to call upon Dr. Phadnis sir to proceed with this session. Dr. Ashish Phadnis sir, all to you now.
Thank you very much, Deepak, and welcome all the speakers and all the moderators. For the first case, we will have Dr. JUJHAR Singh, who will be presenting his case, and the moderator will be Dr. Sachin BHONSLE from Fortis Hospitals, Mulund, who is an MS Orth and an FRCS Orth from Glasgow. He's got special interest in joint replacement, trauma surgeries, and complex trauma surgeries. They run a very successful DNB program at their hospital where he's a teacher, and he's got several publications and presentations on arthroplasty and trauma surgery. Dr. Sachin is also AO trained and AO faculty, and he's a very good friend and extremely accomplished surgeon. And we are really happy to have you here, Dr. Sachin. And Dr. JUJHAR Singh, you can introduce yourself, share the screen, and start the case presentation, please.
Yes, sure. So I'll first share the screen.
Yeah.
So I hope everybody is able to see it.
Yes, sir. We can see your screen.
So myself, Dr. JUJHAR Singh, I am MS Orthopaedics from PGI Chandigarh. Currently, I am the senior consultant and specialist at Ambedkar Medical College in Delhi. And I'm a consultant with Sports Authority of India. And I primarily have interest in complex trauma, along with pelvic acetabular and arthroscopy and sports injuries. So I'll be discussing today regarding the topic which I've been given was a complex trauma. So I'll be discussing regarding some elbow fractures like isolated coronoid fractures today. So that is a topic which has been chosen. Should I start with the permission of the moderator and everyone?
Yes, please.
Yes. As we know that isolated coronoid fractures are not very common, and they are a part of a spectrum of complex elbow injuries involving fracture dislocations. Right now, these, I think most of the times, this term is actually being discarded most of the time, and now we have been specifically focusing on the injuries to the facets of the coronoid, like anteromedial facet or the lateral facet or the body or the basal areas or sublime tubercle. So all these things are the very focus now. So we have been very specific in the management part as well. So as we know, there are two possible mechanisms of injury. There is posterolateral rotatory instability and PMRI. So posteromedial rotatory instability. Today, primarily, I'll be talking about the less common PMRI, that is posteromedial rotatory instability. So it encompasses the spectrum of varus instability mechanisms. That is the varus rotatory instability, which can lead to anteromedial coronoid fracture and can be associated with some ligament injuries like the lateral collateral ligament injury, and very less commonly can also be associated with anterior band of MCL injuries as well. So again, it's commonly due to the fall on the outstretched hand, pronation into rotation, and the humerus rides forward on the ulna, and there is a varus thrust. So again, coming to the case presentation, so let's start with this. So as we can see, the 38-year-old male had a fall on outstretched hand due to road traffic accident. His shoulder was flexed and abducted. And this is a typical isolated coronary fracture, which we can find. The radial head looks fine to me. And I think everyone should agree that we need to assess these types of injuries, and just the AP and lateral X-rays are not enough. So we should be very much particular that again, the coronoid is a 3D structure, and it has a lots of ligamentous attachments as well as lots of associated injuries most of the times, and we should not be missing any of those kind of injuries. And so we went ahead and with the CT scan, so we can see there is a quite comminuted kind of a coronoid fracture, which is into the anterior side, the anteromedial side, as well as involving the central facet as well, the basal area. So it's quite a comminuted one. So again, we can see the type of comminution here, and which is extending mostly up to the sublime tubercle. So this is essentially the classification. So the Regan-Murray, again, all these classifications, they fail to do justification just in a single way. Again, the tip of the coronoid, essentially the very part of the tip, which is essentially 1.9 to 2 mm, is essentially, we can say that we can leave it all alone. But then again, if we go to the zone of more than 2 mm or more than 1.9 mm, that has been described in various articles. So again, type 2 or type 3 fractures typically need type of fixation. And then again, classification goes to the O'Driscoll type, which includes the anteromedial, basal, and tip fractures. So again, we have these options for the surgical approaches. Typically on the medial side, I'll be talking about specific approaches. Now the trend has been more and more on the specific approaches. Like if we are dealing with a radial head fracture along with a coronoid, then we go for a lateral approach. Then can be a typical kind of a Kaplan or a Boyd type of approach. But then again, for the medial sided anteromedial facets of the coronoid, where there is no injury to the radial side, then we can go for various options of surgeries like Taylor sham, which is typically between the FCU and the ulna. Then the split FCU approach, which basically gives you directly the approach towards the coronoid fractures. But again, it will be just next to the ulnar nerve. Then there is a Hotchkiss, the over the top approach, and the split in the flexor pronator mass. So that is what we had planned for this case, to go do a bit of extensile approach, and then again, so that we have a good visualization of all the fracture fragments. So this again was the medial approach. There you can see the extent of injury which was there to the patient. There is an ecchymosis there. So this is a medial approach which we had planned. Again, the ulnar nerve, which can be very much delineated on the proximal aspect rather than the distal aspect. And again, what was
the timing of the surgery?
So the timing of surgery was around 10 days post-injury.
Okay.
Yeah.
Okay. So, Dr. JUJHAR, I mean, I will just go a little this thing for the benefit of the audience.
Yeah.
So, Sachin, I mean, any other thoughts you would have? I mean, he's comprehensively shown us, Dr. JUJHAR, the classification. But any other thoughts you would have on this? Would you differ in the management or?
Yeah, before you did a CT scan, would you also do an MRI scan to look at the soft tissues?
Sir, typically, I feel that in an acute scenario, most of the times the MRI gives a very blurry picture. Most of the time, it will show these types of injuries, which definitely we know that these are ligamentous injuries which can be associated with it. But then again, we can if we see the bony injury, the CT scan, and because again, the coronoid is that type of a fracture, it's like a balcony. So it gives a varus stability to the elbow. So we definitely know that on CT scan that we need to fix this fracture. And again, if we fix it and then we analyze it intraoperatively by doing a complete range of motion and flexion extension along with the full extension, so then we get to know about if there is any ligament injury and we can fix it there and then. So I feel in acute scenario, if we are operating, then MRI, I will not probably do at a first choice. But then again, if there is a very glaring part which I might be able to miss, or I am operating something which is more than beyond 3 weeks or something, I'll probably go for an MRI.
Okay. And how was he immobilized for 10 days?
So the patient was on a slab, and basically they came to us after 1 week, after they presented to somewhere else. And then when we opened up the slab, we got the fitness done, and then they were ready for after 10 days for the surgery.
Okay.
Right. I mean, I wanted to ask a question here. I mean, when you put the patient to anesthesia or so, would you, I mean, is there any role of assessing the elbow instability at this stage? And that change your, surgical tact. I mean, would you be also thinking of, maybe I have to go lateral also to explore the ligaments also? I mean,
Yeah, definitely. So all these injuries have a component of LCL tear as well. So as I have shown that PMRI's injuries or most of the times can be associated with LCL injuries that we can assess intraoperatively after fixing the coronoid. So that is why we are always ready for the lateral part as well, the lateral part of the incision, which we can use to refix the LCL, which as I think, which I have one more case in which we have encountered that. So I think we have to be very open, and these medial and lateral approaches, these two approach, incision approach seems to be better for my in my hands, and then that is a trend I think which we are going towards now.
Okay.
Okay.
Yeah. So should I proceed?
Yes, please.
Yeah. So after identifying the ulnar nerve on the medial side, that can be more done on the proximal part. Then we went ahead, and this is the flexor poronator mass, so that we can see even again you can very well see that here the ulnar nerve has been dissected even distally. So we should not shy away from dissecting it even distally, because then again we need it to be very much relaxed during the whole of the surgery. And then again we need to lift this whole flexor poronator mass. That is what I had planned. I was not just splitting it distally. I was just the FCU has been split over here, and then again the ulnar nerve has been taken quite safely in the backside, and then again this whole flexor poronator mass we can see over here. And this again is the medial epicondyle where whole flexor poronator mass has been attached. So again, to have a good visualization of the whole fragment, we went ahead and we released and excised this whole flexor poronator mass and lifted up from the bone. And this actually, you can very well do a splitting type of approach as well. But then again, lifting it from the bone can very well show the type of fracture visualization, which I think we can very well see in this type of a patient. And again, the ulnar nerve is protected at all the times. So this again shows the fracture fragment along with whole lifting up of the flexor poronator mass. And this again, we can very well see that the humen is there on the anterior, the lateral side as well as the medial side. And this again was the fracture fixation with the plate, which we had performed in this scenario. But then again, there was a large chunk of a capsule, which I think it is not visible in this view. But then again, I should point out this, that all these injuries are typically not isolated injuries. They have a capsular attachment, capsular avulsions or ligament avulsions as well. So again, so this patient had a capsular avulsion here. So we had taken a bite through the capsule, which involved the brachialis. And then again, this was made, tunnel was made through the proximal part of the ulna. And this again was fixed through the capsular avulsion, was fixed over here to give extra stability to the coronoid and the elbow. So this again is the stability of the elbow where the capsule has been fixed and the coronoid has been fixed. So again, the ulnar nerve can be seen very well. So again, the elbow was quite stable. And this is the intraoperative further views, which show this is the C-arm view, which we can see that there is a good stability of the elbow as well, along with the plate and the fixing of the capsular avulsions with the endo button. Again, this was the suture anchor which we had put to refix back the flexor poronator mass back to the medial epicondyle, because we can't just suture it over there. We need a robust fixation of this, and this was the final closure. So where we can see that all of the flexor poronator mass has been fixed with the suture anchor over there. And this was the post-operative view where you can see the good joint alignment, and all of the ROM during the surgery was quite congruent, and there was no laxity which could have pointed out towards any other ligamentous injury like of the MCL or the LCL. So this was again the functional outcome at around 3 months. And we had started the elbow mobilization. I'll just discuss about the elbow mobilization here as well, if the time permits. If the time permits, can I go for the second case, or we want to discuss this case? I'll just have to have an opinion of the house.
What is the anchor at the medial epicondyle? Did you attach the...
This is the suture anchor which we had used, sir. So this is a indigenous anchor only, which is, and which we take the bite through the flexor poronator mass, which we had lifted off of the bone.
Yeah.
And then we have sutured it back and then closed the FCU interval as well, the split of the FCL.
Okay. Yeah.
So if the time permits, can we go for a second case? It's a very small case. So if time permits, then I can just show this very briefly.
No, tell us how you managed it post-op. what sort of, whether you
So,
gave a brace,
yes.
whether you gave a ROM
Yes.
brace and physiotherapy protocol afterwards.
Yes, I'll do that. I'll do that. So again, I just wanted to show this type of a this diagram as well. So
Yes.
typically, these injuries after the post-operatively, they need to be managed in a hinge. I didn't go for a slab or something like that. We gave him a hinged brace, and typically the most important thing is this activity. If everybody can see the abduction of the shoulder, putting a varus stress on the elbow, so that movement has to be restricted. So again, essentially the shoulder abduction needs to be restricted in these types of patients so as to avoid the varus collapse of the elbow. So again, I will like to just point out that again, the ROM should never be restricted. And again, the anti-gravity, the influence of gravity on the elbow is very, very essential. So anti-gravity type of a ROM exercises with gravity eliminated, and along with that, the abduction eliminated, which will decrease the varus stress. And then the ROM, which we are doing it against the gravity, eliminating it. So that will be very, very important pearls, I think, which post-operatively we would like to have. And then again, in many comminuted fractures, again, we can delay the rehab, the ROM by around 2 weeks or so. But then again, in this case, I had achieved a good stability of the elbow intraoperatively. So we had gone for a hinged elbow brace, given it to the patient on second or third day after the wound was better. So immediately the slab was given just to have a pain relief. And after 2-3 days, when the wound was better, then we went ahead and gave a hinged elbow brace and started with anti-gravity ROM exercises, and with strictly advised to the patient that shoulder abduction should be limited to prevent the varus collapse. So, and then again, further, after 2 weeks, the cyst removal was done. ROM was gradually increased. After 6 weeks, the union was better on the X-rays. I don't have the very late X-rays, but then again, the ROM finally was quite acceptable, and I think it will further continue to improve. Just a bit of extension, full extension lag is there. I think that will gradually improve with physiotherapy. That can be due to the capsular injuries or stiffness which can be there. And as we all know, some kind of a heterotopic ossification do develop in these kinds of cases. So I feel elbow is very that type of joint which can in fact go into stiffness very easily. So that was the protocol which we followed. Yeah.
At what stage you involve the physiotherapist?
Sir, most of the time, sir, it is, I feel physiotherapy involvement is a very subjective issue. I feel an orthopedic surgeon is the one who needs to decide upon the range of motion and, the protocol of the physiotherapy. We should be involving them only if there is something which is specifically required in terms of therapy or something. But then again, I like to talk to my patients in my own way and counsel them regarding that. Yeah.
Super.
So if we have time, I can do the second case. I think you have all seen the slides, but then again, it was just a case. It was just a case.
I think your speed is quite good, so we can do the second one.
Yeah, yeah, fine. Yeah. So again, one more fracture, which was again a coronoid fracture. Along with now this here, we can very well see on the X-rays only that there is a lateral ligament injury. Which we can very well see on the opening up of the lateral side of the joint. So there is a coronoid fracture along with the lateral ligament injury. Then there is a chip of the lateral condyle there as well. So this really points out towards the LCL. So this again, I will not need an MRI in this case. Probably I can see this intraoperatively after fixing the coronoid, and then I will probably know that, yes, I will have to do a LCL fixation in this case at some point of time. So this again is the CT images. We can see the coronoid fracture here, the anteromedial facet. So this again was the medial approach which was done. And this again, I didn't lift up the flexor pronator mass. So this I wanted to show there are various approaches which we can use in various different type of cases. So here again, I didn't go for the flexor pronator mass, didn't dissect it much. And then again, this was the lag screws which were put here, followed by the T plate. Yes, I lifted up the FCU over there, and then I fixed it back and then sutured it back. So this was the intraoperative view of this case, which shows T-plate fixation along with the lag screw fixation. And then again, on this X-ray, we can intraoperatively see on view, we can see that the lateral joint opening up is there definitely. So then obviously the LCL insufficiency is there. There is an opening up of the lateral joint. So again, we should be always ready to refix the LCL in these types of cases, which was done with a suture anchor over there. So again, an indigenous suture anchor with taking a bite through the bony part of the LCL, and then again it was refixed, and like a double breasting procedure can be done over that area to reinforce the LCL. So I think this was the second case. So just a bit of take-home messages.
Just sir, Kiruba here.
We have discussed, I think, most of the things, but then again, I'll be happy to open discussion for the house.
Two questions. One,
yes.
Was median nerve of any concern when you went through the on the medial side?
Sir, not really, sir. Not really, because it was typically not in the surgical field. The main concern is basically on the medial side is only the ulnar nerve most of the time which it comes. Rather if we extend it proximally or distally, then that can be a cause of a concern. But other than that, I have not encountered.
Yeah, but here you went anterior to the flexor pronator mass.
So that is why we flexed the elbow and then put the Homan over there. We didn't extend it too much. So that is the problem which we face with the anterior approaches most of the times when we do coronoid fractures. And I was recently listening to one of the lectures probably somewhere. So they were saying that why not to do an anterior approach? Because in anterior approach, when we are going in between the median nerve and the brachial artery and all those vascular spaces and the probably the biceps tendon and all that. So at that point of time, we are at the risk of stretching it. And because we are wanting to extend the elbow at the same time, because extending dislocates it most of the times. So that is why the medial approaches, specific ones, the medial and lateral, are better as compared to the anterior ones, because they allow us good visibility and avoid the complications of nerve injuries.
Okay. Second question is, where exactly was the lateral collateral injury?
Sir, the lateral collateral injury was basically at the lateral epicondyle, which was I think we can see the bony flake over there.
Okay.
Yeah. On this X-ray. So this was actually, we identified it intraoperatively by opening up of the lateral side. By opening on the lateral side, this small incision. And this again, we can see the opening up of the lateral joint. And this was the ligament which was taken through bites through the suture anchor. And then it was fixed to it.
Okay.
And yeah.
Nice.
So I'll be happy to discuss anything else which we can do. But then again,
JUJHAR sir, KIRUBAKARAN here. Are you able to hear, sir?
Yes, please.
Sir, actually, I'm happy to see your cases. From the first case, I think you have increased the screw length. So did anything happen, or was the first case, the screw lengths was really small, and in the second case, I think you have increased the screw lengths.
So I feel the intraoperatively stability of the elbow is prime important. And then again, when we see the stable elbow and stable fixation, we have to, it's actually, it's not a very deep fracture. To be very frank, it's not a chunk of a bone. It's like
so you have done a unicortical fixation, locking fixation, everything.
It's not, we were not having bicortical fixation most of the times. And then again, if it is required, then it is done more on the lateral side. So you can see when the screws are going on the lateral side, they are actually quite good purchase. So these are all, yeah.
Thank you, sir.
So they are oblique view. So they are basically the oblique screws which we are putting through the medial approach. So it is not an anterior direct approach that we are putting a bicortical screw.
Sir, actually, one thing is nowadays there is a modified, that's what you have correctly said, the interval between the biceps and the median nerve and the brachial artery.
Yes.
That approach gives a new anteromedial approach for the anteromedial facet. I think you should have avoided the unnecessary ulnar nerve handling, sir. That's what I wanted to just know, sir. Because
so again, I will try to point out that there are there are many things which we need to discuss about this. If you go for an anterior approach or a modified anteromedial approach, you are directly handling the vessels and nerves front of the elbow. That is number one. Again, number two, which is much less dangerous as compared to ulnar nerve. As we all know, ulnar nerve is a very resilient type of a nerve. And if we handle it correctly, it will not have much of an issue. Number two, again, when we are extending the elbow to gain the access and increase the exposure, the elbow is constantly subluxating. So again, if you want to put in hardware, you will not be able to put a proper plate through it, because these are big chunks of coronoid which we can show. And again, fixing them with just screws will not be sufficient. So we will, most of the time, we will need a plate fixation, and think that we can very well achieve through the sublime tubercle and good bone purchase over the medial side as well.
Okay, sir. So two things have been covered. Third thing is here, as you have peeled off the flexor pronator mass from the medial epicondyle, there's something called a over-the-top approach or the Hotchkiss type of approach, where
Yes.
you split the FPM to gain access to the anterior elbow. So why peeling completely than splitting?
See, you can do either. You can really do either. But then again, the main thing is that to refix back to the bone. And again, splitting a ligament is less preferred for me all the times. As you grow in your approaches, then you will realize that anything which is a muscle, you can lift it. And anything which is, the ligament, you have to protect it on the elbow. Because again, there is an MCL over there, which we need to protect at all of the times. So again, lifting the muscle through the bone, it is much easier for me to refix it back through a suture anchor. And we can definitely agree to disagree because both the approaches are being done. And there is not much of an issue with most of the approaches. Again, what matters is you gain a good access, reduce your fracture, fix it anatomically, and then refix your fracture pronator mass. So that is what essentially is the crux of the matter.
Okay, thank you, sir. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
I think we'll conclude this case here, Sachin.
Yeah.
Is that okay? Any
Yeah,
specific remarks,
thank you.
Sachin, you want to make on both these cases and like a take home
So
for us?
it's quite important to learn all of these approaches and try to hit a comfort zone as to which one is most easy in your hands. The one which is described to take off the flexor pronator mass to protect the ulnar nerve seems to be something which can be learned more easily than the Hotchkiss approach. That's what I feel. And it gives a good exposure. Putting a spike over there to get the right angles to the screw is little bit difficult, but not impossible. The screws have to go at an angle. And then repairing the flexor pronator mass with a anchor, if necessary, that can be done.
Okay. Right, because I think we are quite fussed about getting the angle of the screw and the buttress right. But this was
Actually, JUJHAR sir has importantly presented this fracture. Actually, this fracture is analogous to the posteromedial fragment of a proximal tibia. This fracture fragment is analogous to the posteromedial fragment which we fix in the proximal tibia. So I think he has gone and attacked the belly correctly at the right time by buttressing the fragment right in front of his eyes.
Yeah, but the bone quality is not the same. It's good to get a good fixation. If you're not sure, to pass the suture through the brachialis, bring it out at the back, and suturing over an endo button is also a good idea. One should have handy.
Yeah.
Excellent. Thank you very much, Dr. JUJHAR Singh, and thank you very much, Dr. Sachin, for with us. And we proceed to the next case, and Dr. AGNIVESH BASU is with us.
Thank you, everyone.
Dr. AGNIVESH BASU will be presenting the case, and sir, we can share the screen. And the case will be moderated by Dr. AGNIVESH TIKOO. Dr. AGNIVESH is a MS Ortho and a MRCS from Glasgow, and he is interested in spinal surgery. And and he has done the AO Spine Diploma and a consultant spine surgeon in the Institute of Neurosciences in Kolkata. And I also welcome my dear friend, Dr. AGNIVESH TIKOO, who is a senior spine surgeon from the Apollo Hospitals at New Bombay. And he's a regular feature on most of the spine meetings and conferences that we have. He's very well published in spinal surgeries and has a keen interest in complex deformities. Over to both of you. I think, is that Dr. Mohanty there?
Yeah. I just joined. Sorry for being late. My apologies. Are you able to hear me?
Yes, sir. We are able to hear you.
Okay,
We finished the first case, which was a complex elbow fractures of coronoid, and we'll start with the second case of the spine.
Yeah. Thank you, all of you, for being there. And excellent. I was just seeing the last part of the discussion. Something I learned from the case also. I'm actually traveling in a taxi, and so I just keep my video closed.
Yes, sir.
So let us go ahead with the spine case.
Yeah.
Hi, good evening. Am I audible?
Yes.
Yeah, and can you see my screen as well?
We can see your screen. Thank you, sir.
Excellent. Thank you and very good evening, and thanks for accommodating me in this webinar.
And Dr. AGNIVESH is here, right?
Yeah, I'm here.
Yeah. Sir. Yeah. Thank you.
Hi, Dr. AGNIVESH. With your permission, I would like to start the case.
Oh, yes, please go ahead.
So this is quite a rare case, and this is the only case that I've seen in my life, was only such case. So let's see. The 45-year-old male patient presented with severe low back pain for 5 months. He complained of difficulty in walking for 1 month, primarily due to back pain. He could take a few steps with support. He came with a walking stick in hand. He's a pharma by profession, and he also complained of claudication, neurogenic claudication. On clinical examination, he did not have any neurodeficit, no bowel bladder complaints, but mainly of back pain, which was mechanical in nature. Whenever he started to walk, he also felt claudication. So it's like felt like a regular routine patient in OPD. So moving ahead, I did an X-ray, and this is what the X-ray looked. I mean, my mind was, I was expecting no routine things. So I thought, looking at this, it's like an osteolytic lesion. A lot of osteolysis, destruction of bone to naked eye, lumbar kyphosis. The lordosis is being replaced by kyphotic bone, and there's a lot of bony destruction. So the two things that came into my mind, one was tuberculosis or any kind of spondylodiscitis, and the second was metastatic lesion or something like that. So looking at this, he definitely needed an MRI scan. He went ahead and did an MRI, and this shows something quite bizarre. And looking at this, I consulted my my colleagues also, and looking at this, they all felt it's some kind of a infective lesion, some kind of an infective lesion. So, Dr. Agnivesh, what would you straight away going for surgery, or would you like how would you deal this situation?
No, I would want to know more about this situation, what we are dealing with. So there is a contiguous level involvement. There is a anterior vertebral as well as posterior element involvement. As far as I see on the axial scan, with whatever is there, is that there is not much of soft tissue around the MRI signal change. So in this situation, I think a CT would make us wiser. And do we have CT cuts?
So,
Agni, what could this be? I mean, what are the things going on in your mind? I mean, is it tumor, infection, or a developmental anomaly?
So,
yeah.
So that is why a CT is important, because if we look at infection and tumor, both, they will not present sort of in such a contiguous manner, and both anterior and posterior elements involved. And there is a sharp demarcated margin. And with this level of infection, you expect more soft tissue around it.
Right.
In the axial. So definitely this is something which is rare. We know that. And what we have been classically taught is that if you have a lesion which is in posterior elements, and even if it is spanning multiple levels, it's most likely to be a benign than a malignant one. So this is a standard teaching. So going by that, a CT would help us to understand the level of destruction. Is there a sclerosis around that level or not? And what is the bone loss? All of these things will help us to determine whether it's a bone destroying lesion. Is it a sort of a slow bone destroying lesion where there is a bone forming also going along with it? What it is. So all of this without a CT is going to be difficult to comment.
Yeah, I think that's a great kind of insight into this case. And same, I had the same thoughts as well. Looking at this, I knew that we had to do some sort of an intervention in this patient, and obviously looking at the bony architecture through a CT scan is mandatory. At the same time, I was thinking of getting a histological diagnosis, because the patient does not have any acute deficit. I mean, it's not that I have to operate on him on my next operating list. So I wanted to get an histological diagnosis of what it is, and as well as get a microbiological diagnosis if at all it is a tumor. So I did the CT scan at the same time, and the CT guided biopsy from the lesion. So let's see. Fine. slides are not progressing. Yeah. So this was a T1 weighted image, and I did a CT. This was a MRI report, by the way. It's reported by an experienced neuroradiologist. He also suggested that this could be a infective lesion, inflammatory noted inflammation as well. So just kind of not routine stuff, I would say. And this was the workup, the bone, the blood workup. I did a PSA normal, serum protein electrophoresis was normal. CRP was like kind of mildly raised. Total count 8,000. CCT chest and abdomen there was no other finding. Which I did the CCT to see if it was a metastatic or any kind of neoplastic lesion. I did a CT guided biopsy, and this is what the CT guided biopsy showed. Bone resorption, formation, extensive fibrosis, no evidence of granuloma or malignancy noted. That's what it said. And if you look at this is what the CT shows. So what I see is that there's a lot of patchy destruction of the bone. Lot of patchy destruction. There's expansion of the cortex. There is destruction of the trabeculae. There is loss of bone in 2 to 3 vertebra at the lumbar level. So this is what I see.
So
No significant bone formation I can find out.
Yeah, I agree with you, Anindya. This to my mind, if I have to think of something, I think of this as a vanishing bone disease. I don't know.
Gautam's disease, as you
Yeah.
say. Yeah.
Yeah.
So the same, I also radiologically thought it would be a Gautam's disease. Yeah. The other panelists, Gautam's disease is not only in spine. I mean, it is in other bones as well. So, any other panelists have any experience or idea about Gautam's disease being, of Gautam's disease in such a scenario?
Can
I don't have.
giant cell tumor be a differential diagnosis?
It can be actually.
Giant
There is
cell
the expansion
tumor
of the cortex. There is destruction of the bone. Yeah, osteolysis is there. So yeah, could be giant cell tumor as well. But at the same time, yeah, I mean, as Dr. AGNIVESH pointed out in the very first MRI plate, that there is quite a significant affection of both the anterior and posterior elements simultaneously. That is something very rare, even in tumors, I would say. So this is kind of an homogeneous affection of both the anterior as well as the posterior elements of the spine. So I think that is something against any kind of focal pathology affecting the spine.
So it may be, you can think of aneurysmal bone cyst, giant cell tumor, and secondaries. What is the age of this patient?
45, sir.
45. So
45 secondaries would be a bit
secondaries rare in 45
rare.
years of age.
Yeah.
So
I had
primary-
secondaries in mind. That is why I did a CCT of chest and abdomen to find out. Our center doesn't have a PET scan. I would have done a PET scan if possible. But the CCT of chest and abdomen did not show any other primary lesion or any other lesion in the body.
No.
I have one question, Dr. Anindya.
Yeah.
Is that most of these lesions, when you have in bone, we prefer a open biopsy or a sort of we get a better chunk of bone than a CT guided biopsy, because in CT you can't put a thicker needle, and the crush artifacts which you get because of this thing, you can miss a lot of diagnosis which would otherwise be quite evident in an open biopsy. So did that sort of thought come to your mind, or what is your take on that?
Actually, yeah, I mean, what our thing does is that, like, our pathologist companies, the CT guided is done by the intervention team, and they do it. Sometimes they decide how to get the biopsy from. What imaging modality they want to use for the biopsy. Sometimes they do it in the cath lab suite. They get they get more bigger needles to get the biopsy. Sometimes they do it in the CT console. So it is the pathologist, if they're happy with the samples, then the CT guys, they so that is why I didn't intervene. But yeah, I mean, I would say that more tissue, a wider bone needle is something that we would want to have in this.
And any radionuclide scan or
under local anesthesia,
it did not do
transpedicular biopsy.
Transpedicular biopsy. It was, CT guided transpedicular biopsy or extrapedicular approach biopsy from the vertebral body was done. And that is what did not show any granuloma or malignancy. I did not read that much into this 2 lines, elongated tissue with features of bone resorption formation. I don't know what to make out of these 2 lines, but I was more interested in no evidence of granuloma malignancy. So this is what it is, and basically with all this information, I planned to, because the patient was in a lot of he was symptomatic and he needed because he had a lot of instability features. Could not stand for he could stand for barely a few minutes without support. He could walk a few minutes due to claudication. Instability, he was having instability. So he needed to we needed to do something for him, and difficult to do it. I mean, difficult to plan a surgery at this stage. What could you do, Dr. TIKOO? How would you plan his surgery if at all you're planning for surgery?
Yeah, and in this situation, until I have a diagnosis in hand, I would sort of keep surgery at abyss, unless there is a neurological deficit which compels us to go in.
Right.
I would still try to find out the diagnosis before I sort of go in this patient and offer him a surgery.
Yeah, that is fair enough, I think, because there's so much of anterior column loss, and you have to reconstruct the anterior column, or you have to do something.
Yeah, so you
So
need to know the diagnosis whether
back and fix and come out and say that this is the final surgery that you had. So, but yeah, I mean, I planned for. I was confused. So went in for a posterior fixation with. I did not decompress, but took a lot of bone biopsy. So this is what I did: a posterior fixation, a little bit decompression, a focal decompression at the apex. Took in did biopsy, and I was prepared to go in from the front and do something, depending on the biopsy report. This is what I did, but and the patient was symptomatically improved. He started walking for the next day with support. But interestingly, the histopathology was quite quite. It's out of the box, I would say, from our routine practice. So it showed a Paget series of bone. And we did subsequently measure the alkaline phosphatase. We did subsequently do a radionuclide scan, which showed high uptake of the marrow at this of the marrow, bone marrow at that level. So that is something that's a.
Anindya, if I missed it, why was the if I missed it, just correct me. Wasn't biopsy done prior? No.
A biopsy was done
prior to surgery.
Prior to surgery.
Oh.
After surgery was done, it did not give us this diagnosis. This was you can see this is a clear-cut diagnosis, and this is a slide that we received from the histopathologist.
But you usually, Paget's disease, there is some amount of sclerosis also there, no?
Yeah, it's both bone formation and resorption, so you expect some amount of sclerosis as well.
But is the bone formation also they have mentioned?
So yes, in the last biopsy, that what they said is features of bone resorption and formation. They mentioned that in the last biopsy. I think the histopathologists were also trying to hint something, but to us, to me, it didn't ring a bell.
Well, I think the sample, we should talk on the, procedure of biopsy. It was done by you yourself or someone else?
No, it was done by the intervention radiologist.
It was done by radiologist. Okay. The representative sample.
Yeah. But the histopathologists are happy with the sample that they get from them. Unless if they are not, then they refer it back to us and then we do a transpedicular or a open
how we used to do in AIMS was we used to accompany the radiologist and they would always used to call us. They will always used to call. They never did along. We used to go along with them.
That's a very good point, actually, Deepak. Always the surgeon needs to accompany while biopsy is done, so that surgeon tells, okay, from this particular place you take the biopsy, because they won't know what is the actual place of taking biopsy. That is a good practice, actually. Nowadays, in every tumor meeting and everywhere that we are telling that surgeon should accompany the patient now.
Now, Anindya, do you mean that the radiological picture for spine and other bones are different for Paget's disease? Is it there is something in the literature?
No, I didn't find anything like that. So, what literature search that I did, so for this patient, we started, we measured the serum bone specific alkaline phosphatase. It was quite high, and on the basis of radionuclide scan, alkaline phosphatase and biopsy, we stamped the diagnosis as Pediatric, and we started the patient on yearly like IV zoledronic acid, oral calcium, treated with calcitonin nasal spray as well. Did the whole bone marker, result from IPTH to calcium phosphate, phosphorus, whatever, all bone markers we did. And the endocrinologist opinion was sought, and all this the treatment was done by an endocrinologist actually. And a follow-up, the patient symptomatically improved. This surgery was done. This was done in 2020 during the COVID.
Oh, hello.
I think we lost him.
Hello. Yeah.
Go ahead.
What did you do just?
So basically, we did yearly zoledronic acid, calcium, vitamin D supplementation, and nasal calcitonin. That's what we did. And if you see the follow-up, so this is the surgical treatment in Paget's disease systematic review that we saw. Not many cases were reported, but kind of this is what we saw. And we actually published this case in Korean Journal of Spine Surgery. And this is the follow-up image, follow-up X-ray. And we see that with in 2 years follow-up, there's quite significant amount of bone formation formed. And the patient never needed a anterior column stabilizing procedure, because if you see, there was a lot of bony destruction in the first place, and that construct without anterior column support would have failed. So since the diagnosis was Paget's disease, and we treated him medically, and that worked in his case, so his anterior column bone formation was quite adequate. It got treated medically, and he never needed an anterior column support, and he's doing well so far.
Great. My question to you both: don't you consider regarding the biomechanics of lumbar spine while putting these rods? So now we have converted a lumbar lordosis to a kyphosis.
Yeah. I mean, this basically this patient at that point would have needed an osteotomy to correct the lumbar lordosis and kyphosis. But it was fine because we fixed him in situ at that point, because we did not want to do any osteotomy on a bone that we didn't know what we are treating. So that is it. We're not treating a deformity.
Yeah, I think in that difficult situation, there's not much you can achieve. Your aim was to stabilize and get a biopsy there.
Yeah.
Even I would not think of anterior reconstruction also, especially when I don't know what is the nature of the disease.
Yeah.
So the thing that you splint it and you give it time, since it was already too much in kyphosis, there was no point of trying to do anything which would load the implants more, and sort of, you're going in an area where you don't know what it's inside. Means like, is it infiltrating the perivascular structures and all of that? So I think when you have a difficult situation, not everything can be achieved, and this is an excellent outcome. So
accepted.
Nothing more than that can be achieved.
Yeah.
Well, you can do the osteotomy now to correct if you want, but it's not needed.
Oh no.
Yeah, I mean, if he falls off the top, we can do something. But
I just wanted to ask a question. I mean, we discussed about the biopsy.
Done for this patient, sir?
So, Agnivesh, I mean, in such patients, would you rather do an open biopsy under anesthesia, like a transpedicular biopsy to spine?
No. If you see his whole spinous process are infiltrated, you can do a biopsy under local anesthesia also and mild sedation. You can just give a mild sedation and get that sample from the spinous process itself.
Yeah.
And then once you knew it was Pediatric, if let's say a surgeon got it preoperatively, if you don't knew it was Pediatric, then would the treatment still stay the same?
I think with that level of destruction, stabilization is required.
Yeah.
And the treatment for even vanishing bone disease and all that is all bisphosphonates only. So they basically prevent the resorption, and they tilt the balance of resorption formation towards formation. So net balance is positive. That's how the bisphosphonates act. So
and any of local bisphosphonates as such?
No. It has to be systemic only. Yeah. It has to be systemic only, and mostly intravenous. I think once a year in vanishing bone disease, you give it even more often also sometimes.
Yeah, there is evidence of using it, every 3 months, every 6 months.
Yeah. So you use it more, but again, with that excellent outcome, I think that outcome only, closes all the discussion. Only one thing which was there, I would have not done a CT biopsy in this case. That was the only thing which sort of I would say that I would have done differently.
So what you would have done?
Thank
You would
you.
have done in your own work yourself?
Yeah, because in the MRI, the spinous processes, everything is involved. You can easily get a sample from there. You don't need to
Yeah,
put
because my colleague here who does it by himself. And with
Yeah.
those reasons, he does it by himself in his work, not.
No, now
in the
in
typical cases, we go with the.
Yeah. No, in most of the cases, now we leave it to the radiologist to do it, like in infections and all of that. I think we have also become a bit lazy now. So
Yeah, I would say it's laziness rather than anything else.
yeah, so we
Science is not a
leave it to the
great-
radiologist. But if there is a suspected bone lesion, which is like this, which could turn out to be a benign GCT, like all of these, like ABC, you cannot diagnose only on a needle biopsy. So it's always preferable to do a open or a conventional biopsy and get some this thing. And in this case, the spinous process is right there staring at you. So
Okay.
you don't need to sort of.
Can you just
much.
conclude in 30 seconds, Dr. AGNIVESH, regarding the case?
No, I think Dr. Deepak, it's already done. It was an excellent managed case, eye-opener for all of us. Paget's disease with sclerosis we have all seen in spine, but with such a lysis and all of that is a rare scenario. And my compliments to Anindya for managing this very well. And thank you to you, Dr. Deepak, Dr. Mohanty sir, and Dr. Ashish sir for giving me
Thanks
this
to all of
opportunity.
you for
Okay, you can be there online. Okay, now we'll move to Dr. KIRUBAKARAN. Dr. Ashish sir.
Yeah, just a moment. So this the last case is for pediatrics, and it will be moderated by Dr. Sandeep Vaidya, who's again a very close friend. He has authored a couple of books on pediatric orthopedics and is an expert in managing pediatric trauma. He's a close colleague and works at his hospital in Pinnacle. He's attached to Vaidya Children's Hospital, and he's also a senior consultant at JUJHAR Hospital in Thane. Dr. KIRUBAKARAN is going to present the case.
Just before presenting, can I ask how many years follow-up is of the last case, spine case?
It was from the COVID era, I think. So he's got a 3-year follow-up. That's what he mentioned.
Okay.
Is that correct, sir? Anindya?
I think
He has left.
I think he has
Yeah, he said 3 years.
3 years, yeah.
3 years. Okay.
That's a good bone formation, huh? Good bone formation.
Yeah.
All the color.
Okay. Thank you. Please go ahead.
Dr. KIRUBAKARAN is an assistant professor in the orthopedic department at JIPMER, Pondicherry. And is he here? You can share the screen, sir. I will log out. Looks, yeah, he is back.
Actually,
Sir, I just lost the connection. I just
no
logged in.
problem. You can share your screen, and Dr. Sandeep Vaidya is also here.
Yeah.
Okay.
Yeah, you can start.
I'll just share it in the moment, sir. Yes, sir. So I'll be today just talking about a few points regarding managing a post-traumatic bone loss in pediatric setup. So I work as an assistant professor in JIPMER, Puducherry from 2021, and I finished my MS Ortho from PJ Chandigarh, and subsequently I worked as a senior resident in AIMS New Delhi, and I joined as an assistant professor in 2021. So I get to manage all this trauma and mismanaged trauma. So this was done. This was a 5-year-old boy with a both bone forearm fracture, and I was managed with 10 snail. It was open fracture to begin with. They did a debridement and they inserted 10 snail, and I got the patient after around 6 weeks of initial management. And the patient had a sinus discharging at the fracture site of the ulna. And
Any records about what was the grade of the compound injury? I mean,
it was a grade 2, sir. It was a grade 2 injury with 3 centimeter laceration around the ulna, sir.
okay.
So it was debrided and it was nailed in the single sitting. One of my friends did it, and subsequently he was following up. There was lack of any healing response at 4 weeks, but the patient had a persistent non-healing sinus. He had debrided it, and still he had persistent sinus, and there was minimal sclerosis and gap non-union gap. The fracture gap was extending, and we had followed up. We had done the culture sensitivity on a OPD basis, ESR, CRP, and this was around 3 months after the initial trauma. This first picture was okay, sir. So what was minimal sclerosis at the fracture site, minimal atrophic non-union at the fracture site became a long segment sclerotic and bone and unhealthy bone. So the infection seems to
It
be.
was like that during debridement, some of the fragment of the bone were removed.
No. He had good primary cortical contact to begin
So
with,
within
sir.
a span of I think 6 weeks, you mean that this
Yeah.
much of bone loss was there?
Yes, sir. Yes. So we were quite. The sinus went on to heal over the next 6 weeks. From 6 weeks to 3 months, the sinus healed, but at the cost of the bones getting undergoing lysis like this.
So obviously there was an underlying infective process which was still smoldering beneath, and that
Yes.
was called the
Yes.
lysis of the bone and the sequestration of the bone. Yeah.
Yes, sir.
So the infection was still active, though the
Yes, sir.
sinus had healed superficially.
Yes, sir.
Internally, there was
Still.
still, so this has gone into a chronic osteoporosis.
Yes, sir. So at this stage, how would you have approached this patient, sir? School-going
this,
kid, 5 years.
yeah, just before I come to the management at this point of time, whether, anything different could have been done on day one. So normally, it is very rare that in, children less than 10 years old with a both bones forearm fracture, you do a, operative intervention. Yes, compound fracture is one of the indications for operative treatment in children less than 10 years age. But in this case where where there is a a compound wound directly overlying the ulna, maybe
Yes, sir.
you can avoid direct fixation of the ulna. There are various
Okay.
ways how you can approach it. You can do a a radical debridement. Just place the patient in a cast and create a large window over there, dress the wound, and
Yes,
then
sir.
once the wound has healed, because these children, even if the wound is like 3 centimeters, it will heal off within less than 5 to 7 days. Being a child,
Yes, sir.
being a 5-year-old child, and then following that, you can give a well molded cast. So that is one way how you could have treated it. If you wanted stability on day one, the other way you can do is, it is very well described, is that you do only fixation of single bone. So in this case, since there is no wound which is overlying the radius, you could have just fixed the radius, left the ulna alone, and then once the ulna heals again, put it in a cast. And the third way you could have managed it is a fixator. So yes, fixing both bones with an intramedullary nail is a kind of a risky thing to be done in a compound wound. Uh, Provided you are absolutely sure of your debridement and you're sure that there is no internal contamination, you can still do that. But I would have kept it as a as a third option. Probably I would have probably treated this a bit more conservatively, knowing that the soft tissue would have healed early. Now coming to the the case now, obviously this needs radical intervention. So the first stage would be control of the infection, and the second stage would be the reconstruction of the defect And I suggested you go ahead with your slides and then we can discuss the management.
Yes, sir. So what I did was I removed the nail and I debrided the space radically, removed the diseased bone, and inserted a cement spacer, and then I inserted a 2 mm long K wire. And when the cement was about to set, I inserted the K wire back through the medullary canal. I washed the medullary canal and well with antibiotic loaded saline, gentamicin saline, and then I just added a just fixator for the extra stability for the membranes to form properly. There were
But
some
did you require this external fixator? It would have passed through
actually
the cement. This was
why?
incorrect
Because sir, the ulna with the radius united, I was not sure of the stability. Many a times, I have lost the cement spacer into the soft tissue. One previous case during in a femoral defect management in an adult, the cement spacer ultimately migrated, even in the presence of K wire, and I could not go further because the patient lost to follow up.
Can I just suggest something? For this
Yes,
thing,
sir.
what we take a 2 cc syringe, put cement inside, and after the cement sets, we just cut that syringe. And of course, in the 2 cc syringe, we put the K wire inside, and
Yes, sir.
then you can put it there so that it is a uniform cylindrical cement spacer.
Okay, sir.
Okay.
I understand,
Just,
sir.
just a suggestion. Okay, no problem.
Yeah, that gives a
Okay, go
very
ahead.
smooth, a very
Yeah.
nice, smooth spacer it can be created using the
Yeah,
syringe
I
technique.
understand, sir.
Anatomically spacious.
Yeah.
And also the
yes, sir.
cement, it has to overlap at least 1 centimeter of the intact bone on either sides.
Yeah.
Yes, sir.
Okay, so
I totally get
yeah.
you, sir. Thing is, I was not very aggressive with respect to the proximal dissection. I placed the cement just over the cortex on the proximal aspect, over the exposed bone, whatever I had, and over the distal part of the bone, whatever, as Mascule described, it has to just hug the ends of the bones so that the membrane is extending beyond the healthy bone margin. So that was what I just maybe the bone quality and the cement radio density are matching each other. So the exact interface we are not able to properly see. So ultimately, what happened was the thing which was worrying me was the ulna, which was progressively getting short with 3 months down the line picture. If you can see the ulna in the wrist, sorry for the bad AP view, in the lateral view, the physis is coming proximal to the ulna. So that made me that gave me the thing to distract the ulna intraoperatively using a JES and maintain the distraction. So that's the main point I wanted to put the JES. I could jack open the space at the infected site, but I could not. By 3 months, the intraosseous membrane has contracted, and I could not achieve much of an ulnar lengthening intraoperatively, even acutely, or even I advise the patient to slowly turn the just 1 mm per day. But ultimately, what happened was the patient came with within 10 days with the just pins backed out of the proximal fragment. So we had to ultimately reduce our goals and first aim for infection debridement and union and gap management rather than obtaining anatomical length of ulna. So
Okay, sorry, let me just interrupt you 1 second over here. What
yes, sir.
antibiotics did you mix in the cement and in what dosage?
Vancomycin, sir. 4 grams vancomycin I mixed, and whatever space I could get.
4 grams, how much cement?
140 grams.
So, because in the pediatric age group, there is no real literature as to how much is safe.
But
whether,
I am
this
I am
force of,
using a very, very mild, very less, almost 10 grams of cement only I have used here, sir.
yeah,
Almost
I
one
agree.
fourth.
No,
I mean,
listen to him.
there are no even reported cases of, systemic toxicity due to, your antibiotic, your local antibiotic spacer. But, that's just a concern that I had in mind. So fine.
Yes, sir. Yes, sir.
So you used about 10 grams out of your, 40-gram cement.
Yes, sir.
So
Yes,
in
sir.
effect, you mixed about, 1 gram of antibiotic in the cement that you
Yes,
put in,
sir.
right?
Yes, sir. Yes,
Yeah.
sir. So
Okay. What
ultimately,
cultures did he grow?
he grew staph aureus, sir.
Sensitive, resistant,
Sensitive to vancomycin, sir.
sensitive. So, I mean, so did you give any systemic antibiotics addition?
Just vancomycin, and I allowed him. I gave him some
It was a
cloxacillin as
MSSA
a
or
cover, sir.
MRSA?
Cloxacillin, oral cloxacillin as cover we gave, sir, for 6 weeks,
Oh,
which was sensitive again to the staph aureus.
okay. So cloxacillin, if you give, it has to be at 100 mg per kg per day in
Yes, sir. So we
divided
talked with the
doses.
pediatric
Because,
department.
normally, yeah, for routine infections, it is 50 mg per kg, but in bone and joint infection, the dose is much higher. It is double the
Okay,
dose, 100 mg per kg per day. Yeah.
but I think it was given in the routine dose. I think we missed this point. We didn't give it in the higher dose. Thank you, sir. So
Okay, you can go ahead.
so this was the picture at after 6 weeks. So 6 weeks we repeated the X-ray. The sinus, actually, this guy magically healed any wound around the fracture site. Even after 6 weeks, the wound healed nicely, and but we could not achieve the ulna length. The radius was continuing to grow, and the ulna was settling down. We couldn't do much about that. So we thought that stable ulna would be a better substrate for lengthening, further lengthening. So we had just removed the spacer at 2 weeks later, at 8 weeks interval. We harvested fibula, and we had plated the fibula to the parent bone with the defect without disturbing the membrane. And this was what the picture, and subsequently the fibula was uniting well in the proximal fragment, but distal fragment it was struggling, but ultimately it united well, and he went on to heal the wound completely without any issues. And this was the latest follow-up when he came in July. So 1 year
So how
follow-up.
long is this follow-up?
This is 1.5 years follow-up, sir.
And what was the length of the fibula you required?
I required around 3.5 centimeters of fibula, sir.
Yes, so by and large, and I agree with your, line of management. You see, the role of the cement spacer in these cases is twofold. Number one is, it gives a high dose local antibiotic delivery to, control the infection. And secondly, it helps in inducing a membrane, which then helps in, faster healing and incorporation of the bone graft, which you will be putting in the second stage. And in the pediatric age group, it is quite well accepted that a non-vascularized fibula works wonderfully well. In fact, even much longer grafts, up to 10 centimeter have been inserted. They have been inserted not just in the upper limb, but even in the lower limb, we have inserted. Of course, when you are using it for the femur, you can do a double fibula, just two fibulas you can keep side by side and reconstruct so that you get that much width of the bone you can cover. But overall, I think it is a well-managed case. Only thing now you will have to keep a watch. This is just a 1 year follow-up. 1 year, you said, na?
1.5 years, sir.
Oh, yeah, 1.5 year. So you'll have to keep a watch on the negative ulna variants.
Yeah, yeah.
Because
Sir,
you know
how
what is
to address
happening
that,
there.
sir? How to address that, sir? Any ideas?
The simplest way would be doing a radius shortening rather than ulna lengthening. In the
Okay.
in the forearm bones, it is much easier to shorten rather than to lengthen because of the tough interosseous membrane. Lengthening is not a very easy proposition. So whenever we
Okay.
are faced with this situation, and we see this in post-infective cases like yours, or we see it in multiple exostosis also, where an ulna exostosis leads to shortening. So where there we prefer to shorten the radius rather than lengthen the ulna. Of
Okay,
course,
sir.
provided if that is not shortening the forearm too much. Up to 1 centimeter of shortening can be very easily done, and it is not even noticeable cosmetically. So that is fine.
Okay, sir. Okay. So I think over a period of next 3 or 4 months, we would be offering the same to the patient. To just,
Kiruba, what was this radial wire doing all those years, these days?
sir,
This radial wire, this radial wire.
it's the ulna, it's the radius tens which was put during the primary surgery. We elected to retain it.
Okay.
You can take it out now because, for the
Yeah.
later, any reconstruction you need, otherwise it will be very difficult to retrieve it. Already
Yes,
it may have,
You had already got one chance to remove it that time.
yeah.
So while I think while shortening, I think we will remove it and shorten it, sir.
Oh, great.
Will that tensile come out now? It gets badly stuck actually.
Yes, sir. We will have to devise something.
It's at a very odd angle and it might fracture over there while removal. So that's where your shortening site will be.
Yes, sir. I think that would be the best way to go intraoperative, to break there and take the tens out.
Yeah.
Removal of tens can be one of the most tricky surgeries.
Yes, sir. Yes, sir.
I
Yes, sir.
had tough time removing tens nails.
I think we can do the both, remove the tens and do the shortening at that point. Thank you for the idea, sir.
Great. Great, Kirubakaran.
But overall, well managed case. Thank you.
Thank you, sir. Thank you. Sir, if possible, can I present one more 16-year-old guy with the same post-traumatic bone loss, sir?
Be quick. Okay.
Yes. Okay. So this was a floating knee with a open fracture in the distal femur. The patient came to our emergency with a 4 HB and unrecordable BP, sir, and we resuscitated him with 5 units of PRBC and took him for surgery, did the damage control surgery, and debridement was done. All the fragments, most of these loose fragments were removed, and then he was taken up for fixation. So stage fixation. In the first surgery, we did the femur nailing and femur plating. We removed all the dysvascular and free fragment, and we just applied a cement spacer, and the tibia was having intraarticular fragments, so we did a plating with a nail, and so subsequently the patient is now walking. He's a 16-year-old guy and he's walking with the cement spacer, and it's 2 months. So would you elect to go in and replace it, or would you leave him alone, sir?
No, cement will definitely need to be replaced.
No, his knee RM is 140 degrees to 0 degrees and is comfortably ambulating. He's not even complaining of the fact that he has a cement spacer.
Yeah, but at some point of time, it will loosen, He's just 14 years old.
16 years.
Bony union. Yeah. You will have to give him a bony union.
Okay. So, what sort of graft configuration would you opt in this time, sir?
Yeah, again over here, it would be very useful to put a double fibula, like I just mentioned, So,
Yes,
the same length fibula, you cut 2 struts, tie them side by side, and then you can, hitch it into a graft, into the gap.
Okay, sir. So, would you add a middle plate at this point of time, or would this be sufficient, sir?
Since he's 16, yeah, I mean, you
16.
would have to follow the principles of, adult reconstruction.
Okay, sir.
I would take the opinion of the trauma surgeons here.
I mean, Sandeep, wanted to ask you, I mean, the LDFA also looks slightly...
So at the same time, it can be corrected, There is definitely valgus there.
LDFA can be corrected a bit. Okay, sir.
Yeah, but Ashish, he will require a medial plate here as well. This is a domain of the adult, trauma reconstructive surgeon. Yeah.
I think so. A small medial plate buttress would be required.
Yeah.
Because there is no, medial support there.
Yes, sir.
Yeah, especially if you're correcting the valgus, then you will need to put a medial plate. If you were planning to leave that plate and just exchange the spacer with a bone graft, perhaps you would have been okay. This osteogenic potential seems to be quite good.
Yes, sir.
This
So
is
I will just I will correct the LDFA by just changing the screws and putting a cortical screw to pull the fragments so bit laterally so that the valgus is corrected.
Won't be so
And
easy.
get a
No.
Won't be so easy. It won't be easy to do that in presence of cement there.
No, I will remove the cement and do this, sir.
Yeah.
So during
Then you need to correct put the bone graft and might as well do the osteosynthesis, no?
Yes, sir. Finish. Yeah. I just wanted an opinion because there have been papers in JOT saying that these masculines which are done in a primary setting during the trauma, people elect to leave it. And Journal of Orthopedic Trauma, people elect to leave it. And that's why I was in a double mind whether to go ahead because with a good bone response and is not complaining that much.
so leave
Does
it,
it get loosened?
leave it as it is to let the bone grow around it.
Yes.
So that's
Just
something
like in GCT, just like in GCT, what
yeah,
we do.
something like in tumor. Huh?
Yeah.
Maybe some interesting. Dr. Sandeep sir?
But GCT, I think there is a, it is within a capsule of bone that you are putting that cement. Here it is like a free floating segment of almost, 3 to 4 centimeter of cement. I think it would loosen out sooner than later. What do you think?
Sure.
Yeah, sure. Yeah, it will loosen out sooner or later. There will be debonding of the cement and it will come out.
Okay. So follow what the experts said.
Yes, sir. Sure, sir. I will just keep in touch and I will present the follow-up exercise in the future. Thank you for the opportunity, sir.
Yeah.
Actually,
Okay.
KIRUBAKARAN, just to mention, I mean, Sandeep is very humble. He's not, but Sandeep Vaidya and Dr. Mandar have got a publication, reputed journal on tips and tricks on this. Whenever you're doing the muscular technique about using the syringe, like what Dr. Mohanty sir was mentioning, that using the syringes and then making nice tubes and overlapping that ends of the bone with cement.
Yes, sir. Sure, sir.
Excellent.
Sandeep, could you summarize the case in 30 seconds or so?
Yeah, so I think, reconstruction of gap non-unions in the long bones is a common problem that, we do see. We especially see it in the post-infective scenario, post-osteomyelitis, where, they have not probably been appropriately treated in the first stage or in, extremely virulent infections as well. Now, the principles over here are always, initial, control of the infection. And for that, you need a combination of systemic antibiotics, plus locally, you need to do a thorough debridement, and you need to give a high dose local antibiotic delivery. So that is commonly done. If a second stage bony reconstruction is going to be needed, we do it by, putting a cement spacer. On the other hand, if the bone is not, there is not a big gap, but we just need to control the infection, then we can also do that with antibiotic mix Simulan granules. But in case like what
Is he audible? Now he's not audible to me.
Suddenly, I think he went off.
Okay.
Sandeep, you are muted here.
Not able to listen.
No, he's not muted, but there is some problem.
Not muted, I think.
Okay. Okay, Sandeep, we are not able to hear you. There is some problem with your mic or something like that. Though you are unmuted, but we are not able to hear you. Anyway, let's conclude this session. It's almost 20 minutes, past 9. We have crossed over time. So, dear friends, it's really this was the 12th episode of the second session of Controversy and Consensus in Orthopedics, and we are really grateful to all our speakers and the moderators, Dr. JUJHAR, Dr. SACHIN Bhonsle, Dr. AGNIVESH, Dr. Sandeep Vaidya, Dr. ADNINDYA, and Dr. KIRUBAKARAN for being there for the cause of academics and devoting time for the discussion. And as I have been telling every time that in each case also I refined my knowledge of orthopedics and I learn everything. Learn something or other. 1 or 2 points if you learn from each case, then that adds to your treasure of knowledge. And that's how I am sure that all the viewers must have, enjoyed this session. Now we'll come up with again in 2 weeks' time with another session pertaining to sports medicine and orthoplasty and tumors. Now, thank you. Have a nice evening, and may I hand over to Dr. Ashish Phadnis to conclude the session.
Thank you very much, sir. And it was indeed a pleasure having all of you here. So I thank all the moderators and all the speakers for being with us. I would like to thank Dr. Deepak Gautam for being here. And thank you very much to you, sir, again for guiding us and about the topics. And thank you to OrthoTV, today Gaurav, and to Neeraj, Bijlani and Dr. Ashok, Shyam for letting us use their platform. And we will be back in a couple of weeks' time, as sir said, with our next edition and our next set of cases. See you soon. Thank you very much.
Thank you. Good night.
Thank
you.
you.
Stop.